Welcome to this session. Thank you for joining us. My name is Mitra Siddiq. I'm a writer, editor, researcher, and teaching faculty at the New Vance Health, University of Vermont Larner College of Medicine Global Health Program. I'm also a fourth-year medical student at Stony Brook University, and I will be moderating this session. My main focus area in global health has been on overturning the colonial mindset and practice. And we are very excited for this session. We have some very special panelists here today, starting with Tendai Mashingadzi, who has a truly global perspective, being born and raised in Zimbabwe, pursuing her undergraduate degree in biochemistry in New York, her master's degree in divinity in Texas, and then medical training in Russia. And she has also been a global health scholar in Connecticut. She is writer, editor, site director, and Global Health Academy faculty at our Global Health program. She has written a lot for the E! Magazine, particularly these beautiful pieces for global health and the arts, which are a very poignant series. And she's also a dancer on the side. Next, we have Koa Dung, who is originally from Vietnam, where he became a pulmonologist. He recently completed a master's degree in health professions education in Boston as a Fulbright scholar. Congratulations, Koa, and is now pursuing a PhD in health sciences education at McGill University in Canada. He is spearheading innovative curriculum in the field. He was also a global health scholar at the New Vance Health Global Health Program and is an amazing singer. So we have a couple artists in the house. Lastly, we have Charlotte Chipamanga, also from Zimbabwe. Her background is in nursing and midwifery, nursing and adult education, and holds a PhD in medical education. She is a faculty member at the New Vance Health Global Health Academy. She is also head of a new Master of Science program at University of Zimbabwe that has the goal of producing graduates who are change agents armed with a consciousness to transform health professions education. She will be sharing her valuable insights from the perspective of a faculty member and well-seasoned educator. Our intention today is to host a fireside chat type of conversation with our panelists and have an interactive discussion with you, our audience, during the 30-minute Q&A at the end. And before we get started with our questions, I'm going to present an opening statement just to provide some context and background for this topic. At this juncture, most of us are likely familiar with the term decolonization in global health. Countless articles, speeches, courses, and workshops have centered on this event, with reforms called for in multiple aspects of global health programs, from the content that curriculum should cover, to the source and distribution of program funding, the need for greater representation of low to middle income countries, from decision-making committees, even to first authorship on manuscripts. When we think of a global health partnership, we tend to envision medical students from high-income countries traveling abroad to low and middle-income countries for short-term clinical electives, where they're often given the opportunity to participate in this new country, culture, and way of life with a protected structure that includes the pre-departure orientation, on-the-ground support, access to a full clinical experience, being a participatory member of the medical team, and group trips to local treasures and experiences. Well-structured programs may even have host family stays for participants, as well as safety protocols in case of all forms of danger or disaster. And they often also have longitudinal mentorship for participants on their return home. Less often do we envision medical students and faculty from low to middle income countries traveling abroad to high-income countries for educational and training opportunities. In part, this is because this form of exchange happens less often. It's generally much more financially costly for participants from low to middle income countries to be hosted in high-income countries than vice versa. And on the whole, the colonial mindset and model prioritizes benefits to high-income countries. There are a lot of questions that we're just not asking, including whether these participants are given the same attention when they're hosted in high-income countries, what support they're given in encountering greater challenges like being unable to directly care for patients, access medical records, be limited to observership, and other questions like whether they're experiencing mistreatment, microaggressions, or other biases that are affecting their comfort, their emotional safety, their ability to learn and work. Do they have protection or a platform where they can safely discuss their experiences without fear of repercussion? So amidst this push to combat power imbalances in global health, this topic has been left largely unaddressed. So Today, I hope that we can have a honest and transparent conversation with our panelists where they can shed some light on what some of their experiences have been, what has gone well for them for these global health experiences, and what we can do both on the side of low to middle income country and high income country to provide greater support and comfort to these participants while they're hosted on their global health observerships. And the first question we're starting out with is, what experiences have you had as a participant in a global health observership or training? And did you benefit from this experience, and how so? Koa, let's start with you.
My name is Khoa. I just want to give a short introduction about myself again. So I'm from Vietnam, and I think today what I'm gonna do is like try to share from my experience how I did what I did, how I felt during my time in a global health program in Connecticut in 2018. So I spent 3 months in a clinical observership in Connecticut in a teaching hospital of the Nuance Health System, and to me it was a positive experience. Even though I noticed there are certain areas that I can improve. So first of all, so today I'm looking forward to I will try what I want to bring to the table is from my own experience and my own reflection, and hopefully we can listen to other fellow panelists so that we can have this insightful discussion how I got a positive one, but it can be improved. There are certain areas that can be improved. So how we can do it together. So I think I will structure my experience in the global health program in 3 parts. It was in clinical experience of education and research. And I will start with clinical experience. So my background is a pulmonologist. And at that time, I was becoming a faculty member as a young faculty member going from Vietnam. And that it was my first time experience inside of a hospital. So it was a fascinating experience to see what really doctors at my college from the US, what they do every day in a hospital. So that was an opportunity for me to immerse myself in the environment and to see how the resident, how the medical students, how the attending spend the time their life in hospitals, what I can only see in the movies or read in books. So that's something new to me. And it's also allow me to engage and talk with all the doctors, attendings, medical students, fellows, residents. So it was kind of really interesting to me. That's a new thing. So I want to begin with the positive things. It was really good that I learned about Vietnam is we got a very structural and hierarchical system of healthcare and health science education, medical educations. So most of the time we follow the orders of our attending our professors. But in the US, I learned about the collaborative discussion, team shared decision making between team members, and also I learned about multidisciplinary teamwork, which is also new when the nursings can give experience, can share the insight with the doctors, and they can work as a team to develop a management plan. That was a new thing to me, and I think that really resonated with me and changed how I see that. Wow, there's perspective, there's information, the insights from all the team members in the healthcare team. That's something I learned. And at that time, I was purely an observer, so I cannot touch patients. I cannot talk directly to the patient. So I may say hello, say hi, but then I was not allowed to elicit the history taking. I cannot do any performance, physical examination or procedure. It was purely observations, and I was pure observation. I was shadow an attendant, and luckily my attending was a very, I think very instructive, very respectful, and she's fully aware of my limitation, the limitation of my experience. So she always tried to encourage me to talk and discuss the management. She opened for different ideas about the patient management afterward. So that's what I did. There was no touch, like no talking directly to the patient, no touching the patient to do any physical examination or procedures. That was only purely discussion. And then I think like my clinical observation also give me to observe that different way of the healthcare system. Like in the US, the healthcare system more about the patient autonomy, but in Vietnam, it was more like paternalistic in a way that the patient often like yield to the doctor's like a prescription order, and the doctors often do not sought the patient, do not seek the patient's like ideas, preference, and values. So that's something I learned. Regarding the patient safety, I think this is a very important point in like global health scholar program, both in the high income country or low middle income country setting. Like like when I was in the US, I cannot touch a patient, I cannot do anything, and it's well because of the patient dignity or the patient safety. But then back in Vietnam, when I welcome like others like medical students or medical trainees from the US, most of the time we allow them to talk directly to the patients. My Vietnamese patients are very welcome to talk to them. They're really welcoming, very hospitable, and then I often allow them to do like procedures and also to guide them to the procedures of my patients. So that's something that's not equal over there. Like a fully qualified doctors cannot do any procedure, even like talking, do history taking in the US, like myself. Then a medical trainee, a resident or a medical student can communicate with the patient directly and even can do procedures. So that's something I think this is not an inequalities over there. So yeah, so I think I want to say that my experience were really positive in general, but then I can point out that there are certain points that was not like it's not at the same level yet regarding the patient safety and the limitation of being a sole observer. So that's my 2 points right now.
Thank you, Koa. Yeah, those were all really pertinent points. And yes, we will be structuring the categories of education versus clinical versus research just to help stratify the many layers of what these experiences entail. Tendai, what about you? What are some of the positive experiences you've had? And also feel free to introduce yourself with some points that I might have missed.
Hi, everyone. My name is Tendai. And I, like my colleague Koa, spent time as a global health scholar at Newark Hospital in Connecticut. Before that, when I was still in medical school in Russia, I did an observership at Midstate Medical Center in Connecticut as well. So 2 different hospitals, but within the same region. And both were observerships, again, like my colleague. My experiences were positive. On the whole, I learned a lot, but as we will see and discuss, there are definitely areas that can be improved upon. So in terms of my clinical experience, as an observer, I did not have access to electronic medical records, which limited my ability to engage in patient cases. I will say that I was fully integrated on teams with medical students, residents, and fellows. So in terms of morning report, teaching rounds, didactic sessions, I was part of the team and could follow along procedures. I was observing again without being able to participate practically in procedures. But with that integration into the teams, my clinical experience was beneficial. I learned a lot in terms of patient management, in terms of transferring patients from one department to the next, if it's admitting to the ICU, admitting to the wards. I went through all those processes with my team. And so that was something that was very enlightening and very different from my experiences in hospitals in Russia, as well as in Zimbabwe. In terms of education, this is where I was fully integrated into what was happening at the hospital. So as I mentioned before, on the wards, in ICU, on rounds, but also noon conference, grand rounds. I was able to fully participate in those sessions with the residents on the teams that I was working in. I was even given the opportunity to present at noon conference. So I presented a lecture on AIDS-related Kaposi sarcoma in Zimbabwe, which is something I had experienced in the KS clinic at Pararinyatwa Hospital, but something that's not very common in Connecticut. So that was something that I was able to teach. And so I wasn't just a learner, but I was able to be involved in teaching as well. And great discussions came up after that, and was able to engage with a lot of the residents that were within that session. In terms of mentorship, I had a great experience. So my mentor and supervisor was so open and so willing to help me connect, not just with her, but with other doctors within the hospital who had similar interests to me, with mine, as well as to connect me to different departments and areas of the hospital that I might want to observe in. And so I was able to talk freely with her, to engage with her, and she even invited me to a Women in Medicine event that was happened in an evening at a hotel outside of the hospital. And during this event, I met other attendings, female attendings, who were there just to give advice, to talk with residents who were there. And so I was able to engage with a lot of the faculty and attendings through that event and follow up with them afterwards, which was great. So a lot of positives, even with the sole observership limitation, and a lot that we can build upon moving forward in terms of equalizing the experiences of participants from low and middle income countries and those from high income countries. Thank you.
Thank you for sharing, Tendai. So it seems like from Koa and Tendai, we've heard a lot of the positives included mentorship, being able to engage on the team, even though they were limited by the observership model, being able to go to events and kind of be introduced to this non-hierarchical model, which might be different from some of the other places. And Charlotte, we'd love for you to share a few words with us about you and also share some of your positive experiences.
Thank you very much, Mitra. Greetings to everyone. As you have heard, I'm from Zimbabwe and from the University of Zimbabwe, working in the Health Professions Education Department. So meaning we are responsible for the quality of teaching and learning in the medical school and in health professions education in general. Now, my experience with a global health visit to Vermont was highly positive. I came out with more positive than anything else. Now, so I'm speaking from the perspective of an educator in health professions education. In health professions education, currently the buzzwords are blended learning, integrated learning, early clinical exposure, and all that. We struggle with those. We struggle with the implementation of all those concepts in our context. But when I visited the University of Vermont, I saw it in action. I saw it firsthand. I then understood why or how it's actually possible that it is being done. Just the infrastructure alone, classroom infrastructure, for instance, makes it possible to apply interactive teaching strategies. Whereas in our setting, we have lecture theaters or lecture halls that do not allow for like small group interaction if you are dealing with a big group. But the setup I saw enabled that kind of teaching strategy to be applied. Now, looking at teaching clinical skills, for instance, the setup of a simulation, the simulation laboratories, to me were mind-blowing, because we hear those things I had been hearing them, just hearing about them, and of course, seeing videos on YouTube and so forth, but seeing it in reality makes a huge difference. So I was impressed by this setup of a clinical skills being introduced early in the program by standardized patients using simulators and all that. So I wished we could have even simpler versions of it for us to also be able to introduce or teach our students clinical skills and then introduce early clinical exposure. Now, coming to the clinical experiences that the students have or the clerkships, I was at Danbury Hospital in Connecticut for a week. I also encountered other mind-blowing experiences. Just the standard of care that is given to patients, just the way the students are treated, the learning opportunities that are made available to them are really, I mean, comparing those with our setup is like comparing chalk and cheese. So I kept thinking, wow, how can we have this also in our setup? Now, when it comes to research, I encountered experiences where I thought there are several or multiple opportunities for us to do collaborative research. That is low-income country and high-income countries. We could do collaborative research because we could be working on the same things. Now, with these technology-enhanced approaches, why can't we do it? Similarly, mentorship. Why can't a low-income student be mentored by someone from high-income countries and vice versa? Because all of this can happen online. So I came out with a lot of positive experiences, and my mind was opened up to looking how to transform our own systems. Thank you.
Thank you, Charlotte, for sharing those valuable insights from the educator perspective. So we heard you say that you had the opportunity to see a lot of education, innovation in practice, and observe some learning opportunities and start to brainstorm ways to utilize technology to enhance collaboration between the two sides for students, which are all really important points. So now that we've discussed Koa, go ahead.
Or I just want to like jump in, like follow up on Tendai and Charlotte. I think like my experience was like improved a little bit from like what Tendai had. So there must be improvement, like continuous improvement in the program, because I was having the access to the EMR. So and then my mentor would discuss about the patient's information in advance. I already signed the HIPAA, like the chart of information before like getting access to the EMR. And then we discuss the patient information and develop a plan to interact with the patient. So it was, I think there was improvement in the program that we both attended like in time. And second thing is that I want to mention that like we both mentioned about like the system-based practice. So that kind of like is not individual like clinical care, but about like system-based practice that sometimes overlook like from where I'm from, like in our health professions education, we often overlook those competencies, which ACGME, like in the US, they like focus in one of the 6 core competencies. So that's something I think that's also good to know that like even just on the clinical observer, but we can also like we cannot do the clinical maneuver, but then we can focus on other things. That I remember that I focus a lot on how to manage the patient, how to manage the patient flow, who's the physical assistant, who the medical assistant. So those things are also like clinical competence, but separately in another like group of core competencies. So that's something I also learned. Also say that like I want to say that Charlotte, like we met before, and also like I want to say that like I also is very passionate about health professions education, especially after this like global health experience. When I see that like medical education and health profession education can be different and can be done differently. So there's a lot of like opportunity for global health like program to roll. And one thing I want to say that I just realized that on this experience I recalled, Tenda recalled, and Charlotte recalled right now, it was not like as like anticipated when I began my global health scholar program. Everything was just like you will be there, and there was no like anticipation of any like those specific benefits in advance. So those are things I recalled afterward, just to point out that one.
Yeah, thank you for that. So it sounds like there were a lot of surprising benefits that maybe could not have been anticipated beforehand, and some improvements certainly in a program over time, which is the direction that we would like to head in. So now that we've talked about some of the positives, let's dive into some more of the meat of the conversation of the ways that these experiences can be improved. So our next question is, what forms of structural discrimination are low to middle income country participants subject to during their time being hosted in high income countries? Tendai, let's start with you.
Thanks, Mitra. So as both Koa and I have mentioned, this limitation of an observership experience only. And I think the question to ask is, where does this limitation come from? There are, of course, issues of insurance and things like that that can be worked on prior to a participant going to a high income country, but we also have to look at the history of it. So sometimes inherent in the designation is an underlying distrust in the abilities, in the integrity of a participant from a lower middle income country. And this colonial mentality that doesn't trust education systems from other countries, it's part of what leads to doctors having to retrain when they go to high income countries like the United States, because their training is not held on par with training in the United States, regardless of what kind of health system they're coming from. It's all sort of lumped together. So we have to take that into account, and asking those questions of why will help us as we try to move forward in terms of correcting some of these issues. But a large part of the draw for lower income country participants to go to a high income country is to participate in things that are not available to them in their country. So for a medical student or a resident, things like electronic medical records, they're probably using paper charts where they're from. Things like point of care ultrasound are not available. Ultrasound guided intravenous insertions are something that's not widely available to everyone in the hospital. And so to go on an experience like this and then be a sole observer and not be able to engage in these experiences, I think is very limiting, and it just reduces the scope of education for the lower middle income participant, regardless of all the other benefits that we've talked about outside of that. But I think that's one of the biggest draws and the hopes of someone coming from a low income country, is to not only see the things they've read about in textbooks and watched on videos, but be able to use them practically and experience them. And so I think that within the system has to change in terms of assessing the type of background that someone is coming with when they come to a high income country, and putting them at the right level in terms of their abilities, in terms of their knowledge, in terms of what they can contribute during that experience. In terms of research, in recent years, helicopter research or parachute research, different terms, has come under scrutiny, and the longstanding neocolonial practice where researchers from high-income countries come to low-income countries and conduct research at the expense of practitioners and researchers within that lower-income country without the proper recognition of their efforts, has been that many low and middle-income participants do not have research experiences on par with their high-income country colleagues. And if they do have research experience and they have the opportunity to be involved in research projects, the opportunities to publish are not the same for lower middle income participants. It requires money, it requires access, which they don't have. So instead of being first, second authors on some of these projects and papers, they end up being seventh, eighth authors. And again, that just perpetuates that the work that they're doing, their knowledge, their research is not on par with that of a high income participant or colleague who then gets named as first author. And so again, that within the system in terms of how research is conducted, who gets recognition for it, and just even within research, I think some of my colleagues talked about just access to data. If lower middle income participants don't have access to the same data pools, their research is limited, and that's all structural things within the system that need to be corrected, so that, you know, once that discrimination has been removed, we can come closer towards, you know, equal opportunities within research. In terms of education, I want to touch on curriculum. So the learning objectives, I have found for lower middle income participants when they come to high income countries are not always very clear. They're not always well defined. So there's this general assumption within the system that a lower middle income participant is just lucky to be in a high income country. And so with that underlying, you know, underlying thinking, there's not enough work taken to plan out their curriculum, to plan out their learning objectives, so that they have a full experience. How are they going to be reviewed? How are they going to be evaluated? Is there someone after the experience who's making sure that the learning objectives were met? I found that for high income participants coming to lower income countries, these things are more structured, they're more set, and so you can evaluate the experience, you can improve upon it because they are objectives and they are things that are set beforehand, rather than just go and see and experience and good luck, which sometimes is the, you know, the underlying feeling when lower middle income participants come to high income countries. And then the last thing I want to touch on is in the area of mentorship, with our breakdown in the 4 areas. And in order for a mentor-mentee relationship to work well, it must function to some extent according to cultural norms. As my colleague Koa mentioned, in lower middle income countries, we often have a more hierarchical approach in hospitals and the healthcare systems, and whereas in a high income country, certainly at Norwalk, where we both were, we experienced a more collaborative approach where students, residents, fellows, and attendings, you know, they brainstorm together, they discuss together, and they come up with patient management plans together. So in terms of mentorship, it's well and good to assign a mentor to a lower income participant, but without an explanation, a sort of pre-departure orientation on how these relationships work in the US, it can be very difficult for a lower middle income participant who's never been to the US to fully engage in that relationship. So just like a casual meeting over coffee in the cafeteria with your mentor, you know, if you're not somebody who's used to having coffee with someone who's higher up than you, you might not, you know, feel comfortable in that type of meeting place if you're used to more meeting in an office setting. And so again, just the cultural competency, it's not just for high income participants coming to lower income countries, but it should go the other way, where there's some sort of cultural competency training that's given, especially in this area of mentorship, in this area of professional relationships and how they differ in day-to-day interactions within the healthcare system. Thank you.
Yeah, thank you for all these really, really pertinent thinking points, Tendai. So just to summarize, we heard you talk about this theme of an inherent distrust of the skills and abilities and expertise, which is actually something that one of our audience members, Dr. Alexandra, brought up in the last panel as well, that is just inherently limiting. And obviously, as a medical student in a high income country, you can go to a low and middle income country and have access to everything and have direct patient care experiences, interview the patient, do a physical exam, and just the disparity there, that even a well-trained physician coming here doesn't have that same educational opportunity. One of the things I thought that was very interesting that I had not ever heard anyone talk about before that you brought up is that a lot of participants from low and middle income countries are coming here excited to have access to these new technologies, whether it's the EMR system or point of care ultrasound, and the disappointment that must be felt when you're just stuck watching and not able to participate, which made me curious whether any three of you can speak to whether there's any access to simulation lab or procedural skills lab or anything like that. Because I can say as a rotating, I'm a fourth year medical student right now, and on my way rotations, the institutions that I'm rotating through, even as a guest student, I do have access to those things outside of direct patient care.
And now you go first.
Okay, I will jump in here, and so I will say I was fortunate in the observership that I did at Newark Hospital. So in terms of point of care ultrasound, I was able to participate. So my supervisor, when I was in the wards, was very accommodating. She too was an international medical graduate, and so she was very understanding of where I'm coming from, of just wanting to experience the system in the US. And so in terms of bedside teaching, we did do a session on point of care ultrasound. I was able to participate alongside the residents. And so that was very, very enriching. Simulation lab was another thing that she ran. Unfortunately, it was right before COVID. So COVID hit and the sim lab was closed, and so I didn't get to experience the sim lab on that occasion. But I just do want to point out that this is not always the case in these types of observer situations. So I was fortunate in that I got to experience those things, but it's not something that's built into observerships for lower middle income participants, which is something to work towards, so that all participants can experience those things.
So I also kind of lucky because I got kind to have one simulation when they perform a code blue on a simulation center at Norwalk Hospital with an educator, a nurse educator. So I learned a lot. Like I learned about the working with the models, like simulation, how teamwork in the code blue. I learned a lot, but then it was only one time, and we know like simulation is expensive, and then like we add participants from low middle income countries. Sometimes we feel that we're not entitled to ask for those things, so it's more opportunistic. And then it's never something we planned for, so we're just lucky to get a chance. And also I want to point out that sometimes we feel that we do not have insurance, international insurance. So maybe we cause damage to the model, cause damage to the machine. What will happen? How can we pay for it? So those feeling, maybe structural things, and also personal feeling, limit opportunities. And we feel we feel lucky. I think that's the very poignant word that Tendai mentioned today. You should feel lucky, and that's very colonial to me in some way. And I do have a list of my own structural discrimination I noticed. So if Mitra allowed, I can dive in.
Yeah, go ahead.
Yeah, thank you, Mitra. So I think my first one was also being a sole observer. And I think it's always good to compare with what the student from high income country can do. So that's really different. And then I think a clear objectives that Tendai mentioned. And I also think that there's also an implication of you being lucky to be in a developed country, developed system, but also there's an implication that the system in the US or in other high income countries are always more advanced. Kind of you will learn because you go from somewhere low, you will go to somewhere higher, and you will learn something. So that's something like I think like we should notice that one, like when you don't have any objectives, you don't discuss in advance, and you just put people in, and you're lucky, and you must learn something because we're good here. So those are some hidden indication that we may feel as an participant from like low middle income countries. And I will move on to like there's something about like I think it's like the focus was very like partial, like it's always focusing when we talk about like when we were asked about like how our experience, when we were asked to share our experience from low middle income countries, the focus is often focusing on the lack of resources, the deficiencies, the suboptimal standard of care. So those focus create a sense that we're just problem. But and this really deep into my heart, and it hurts me a lot, because I noticed one time when I share about my medical system, healthcare system in Vietnam, I have a feeling that I tried to be more pathetic, to make the situation to look better, so that in competition to all the friends from all the lower middle income countries. And that's horrible feeling. When I noticed that, I had that kind of victimizing myself to please all the participants, to please the medical student, the trainees, their curiosities, their sympathy. That was horrible feeling. And I think that's something we should avoid at all cost. And that's a damage to I think it's a moral injury to myself during that time experience. And there should be more talking about how resourceful and how creative, how adaptive that we develop our healthcare system given our situations, and how we have been like growing and developing our competencies to meet the need of our patients, of our people in our setting. So that's something I think we should focus more in our sharing and discussing. And there's also like we should talk about how like higher income countries, they can learn from low middle income countries, because we develop a lot of like adaptation to different situations. We got a lot of creativities, and there's a whole like examples about how to like with now I think they call like backward like learning, like you get lessons from like low middle income countries, and then you use it back in high income countries. There's a whole literature on those things, and we should focus on that one to give the a balance. And also, I think this kind of like focus will like enhance like the severe complex and de-emphasize the agency of our participants from low middle income countries, and also prevent the learning direction of the high income countries, prevent their learning from our perspective, from our solutions. And then the fourth one, I think there's always a focus, like kind of like always like Vietnam and US, Zimbabwe and US. So like US kind of like the center on the connections. And there's no connection between the global south. I kind of think, correct me if I use the term like incorrectly or inappropriately. Kind of like there's no alliance, there's no learning between like me and Charlotte, me and Tandai. We did not have that kind of interaction a lot in global health programs, and that's something I want we have in the future. And I think it's a structural discrimination when we always like focusing around the US. That's yes. Okay, so that's my point.
Yeah, thank you, Koa, for sharing all those really, really pertinent points. I think what really stuck out to me about that was working on creating a more of an empowerment model and giving agency to participants to have more impact on their own education and more control, rather than just like passively riding this wave that's created for them, and trying to establish more connections between low and middle income countries while they're there. and hopefully trying to prevent that kind of moral injury in the future. And I'm curious whether, just to pitch it out there, whether asking participants about their areas of expertise before they come to high income countries and arrange sessions for them to teach the teams, and off the bat have that mentality that they are here to teach as well. And I know, Tendai, you mentioned you had one of those experiences to do so. And Charlotte, I know you had your hand up. I will get to you next. I just wanted to ask Tendai, you had your hand up a few minutes ago. Not sure if you wanted to add to this before we move on to Charlotte.
No, sorry, I'd forgotten to lower my hand, so you can move on.
Okay, no worries. Charlotte, please go ahead.
Thank you, Mitra. I'm speaking again from the perspective of an educator and following up on the experience that I shared earlier and the experiences that Tendai and Kwa have shared. Clearly, we need to be thinking more about how to address these issues. And one of the things that I believe strongly about is to strengthen undergraduate education, to revisit that area, and again address those issues of colonialism, neocolonialism, and so forth, to make sure that we are going back to the basics and then working up. So thinking along that trajectory, we are running at the University of Zimbabwe a new Masters in Health Professions Education program that started last year. And the first cohort of that class will be coming on a visit to the US, to Nuance Health, because ideas and visions are limited to what you know. So if you don't get exposed out there, you won't get to know how things are being done elsewhere, and how you can also then pick up ideas, transform your own systems. So these are senior students who are coming. They are postgraduate students. One of them is even the dean of our medical school. The other one is an OBGYN. Another one is a physiotherapist. So these are students of a high caliber in terms of what the experiences we have been hearing, those of undergraduate students. So these are postgraduate students. So it would be interesting to see how they can be accommodated in the high income country, so that they feel comfortable enough to share their experiences. They feel comfortable enough to show that they have it. They are qualified. Tendai talked about this inherent distrust, which is in the mind of the colonialist. That same mind is also with us. We also have some inherent distrust of ourselves when we are pitted against the other. So we need to work on all those finer details to enable us to be on the same platform eventually. So I'm hoping that when these postgraduate students come, they will be in a position to identify strategies for addressing their own issues, to come up with homegrown solutions based on what they will have seen. What can they adapt? What kind of assistance is needed? And so forth and so forth. Thank you.
Yeah, thank you for sharing these points and your perspective as an educator. I'm curious about this idea of creating a debriefing space. What do you or the other panelists envision that space looks like? How frequently does it happen? Is it in the form of an additional, maybe an anonymous survey after the fact? Is there a reporting system in place? And if we're going to have a moderator of these sessions, who should be moderating? You know, should it be a mentor on which side, or should we be bringing a psychologist from somewhere? What do you think?
I'll just jump in here. I think debriefing on both sides of the exchange is important. So if a lower middle income participant, for example, has come to a high income country, a debrief with the supervisors during that experience would be good and helpful to the high income country that's hosting, to hear from them before they leave. And then a debrief on the side of the organizers in the lower income country in terms of how the experience went coming back home. So I think debriefing shouldn't just be limited to one side, but both sides of the exchange will benefit from reviewing it in terms of being a host and in terms of sending participants and being a participant within that exchange.
Yeah, absolutely. Thank you for sharing that. I know that in some programs, or our program, for instance, medical students from high income country in the US going abroad write these weekly reflections that are sent to the team. And that way they're able to be read and reviewed, and you can kind of identify if somebody's having a hard time or having a difficult emotional experience. Do you think that something like that would be helpful?
Yes, so as someone who's been involved in the Global Health Diaries, I definitely think that's something very beneficial and a chance for participants to reflect on their experiences. I think, like you mentioned, a lot of in terms of how they're managing emotionally, you know, psychologically, it comes out in those reflections, and you can evaluate the program in a way that you can't when you just say, how was your experience in this? Did you get to do this procedure? So I think finding different methods of evaluating and sort of compiling them together, so you get a fuller picture of the experience of participants, whether they are in a high income or low income country, is beneficial.
Yeah, thank you for that. And sorry, Cole, real quick.
I also want to chime in, like when Tendai mentioned about like debrief within the mentor-mentee relationship. I think it's one of the things we can do, definitely, because like they have a sense of safety and trust in that kind of relationship. And also think that we can also organize, like, I think like at least once in global health rotations, that we bring partners from low middle income countries together. And then I definitely think, given the power dynamic, the facilitator should be in the best scenario should be someone who from like low middle income countries, maybe like Tendai, who has experience and invited to host like that kind of debrief. Given the power dynamic, we don't want to like displease people who already fund us, and also like given the different in power, like I'm a guest, you the host, and also like there's already a mentality of being lucky. So like many people has to overcome those things to touch on those things. And also I think there's opportunity for narrative medicine when we can talk about like some certain stories and experience, and then we can make it as a safe space so that people can talk about like those kind of like colonial mindset and microaggressions. Those things I think would be helpful.
Yeah, thank you all for commenting on that. I think it is really important to build a system moving forward where we can have a pulse on how participants are feeling during their electives, so that if something is going wrong or they had a negative experience or there's anything that can be done to make it better, it can happen in real time rather than after the fact, which is the same type of support that we do give to students from high income countries going abroad. So we've spoken a lot about some of these structural barriers to equality in these exchanges. I'm curious now to hear about some of the forms of personal discrimination that participants might be subject to during their time being hosted in high income countries. Tendai, how about we start with you on this?
Okay, thank you, Mitra. I do want to preface this section with, all in all, I spent many years in the US, and my experiences were largely positive in terms of discrimination. I didn't really experience anything, that has stayed with me or anything like that. People were very welcoming. Of course, you notice little things along the way. But I do want to preface it with that in Connecticut, when I was in Syracuse, even in Texas, which gets a bad reputation, I felt very welcome. And it's more smaller things that, and I had been to the US before, so I knew what I was getting into. I knew what to expect. So some of these small things might be taken differently if someone is coming to the US for the first time. So it is good to touch upon these things. So the first thing I want to talk about is accent. So low and middle income participants are often immediately judged while in a high income country by the way that they speak. So the colonizer mindset and colonial mentality on the lower middle income side often equates non-standard, and that's to say non-Anglo accents, with a lack of intelligence, rather than the acknowledgement that if someone speaks with an accent, it means they speak a whole other language that you don't speak. And so that judgment, you do feel that from people when you come to a high income country or when you come to the US. And I think that's something that makes lower middle income participants stand back a little and not participate fully, because they feel judged because of the way that they speak. And so preparing them for that in terms of orientation on the lower middle income side, and also education on the high income side in terms of accents, what to expect when you have participants joining your teams from different countries. The second thing I want to touch upon, and this is in the medical sphere, is terminology. And so low middle income participants often struggle with terminology in a high income country. So for example, acronyms are used in hospitals all the time in America. And so a low middle income participant at first might seem to not know what's going on or to not be knowledgeable, when really it's more of the acronyms and the terminology that's being used. They might know the process, the procedure, whatever the meat of the discussion, but might be a little slow catching on because of the terminology. And another example of this is in terms of medications. If we're talking pharmacology in the hospital, the use of generic names and brand names, a lot of brand names are used that may not exist in their country, so they might know that medication very well. But if a brand name is used, they might be slow in catching on. And so just understanding that that's also something that a low middle income participant is dealing with and trying to catch up on within their experience. And the last thing I want to touch upon is in terms of this personal discrimination, is in terms of appearance. And so again, we talked about how there's not usually a very good orientation on the side of the lower middle income countries before people come to the US. So in terms of dress in the hospital, sometimes that's not covered. And this can play out in two different ways. So in some low middle income countries, especially those that are former British colonies, a lot of the doctors get very dressed up. So you find, in the hospital, suits, heels, it's not common to wear tennis shoes to work. Whereas you come to a hospital in the US, doctors are dressed business casual, but you can wear your tennis shoes, which is not something that you might find in your country. So just little things like this, when you come into that environment and you're not prepared for it, it just hinders your experience a little bit, at least at the start, where you feel like you don't fit in because of in terms of appearance and dress and what's expected of a medical professional in a high income country. It's a little bit easier in rotations where you wear scrubs, because then everybody's kind of dressed the same. But in rotations where you're not in scrubs, it becomes an issue if there's no preparation in terms of what's appropriate to wear. And also if the lower middle income participant has that type of clothing within their wardrobe as they come on that experience. Just little things, but that do affect someone's experience when they're coming to a high income country.
Thank you for sharing all these. Sorry, Ko, I'll get to you in a second. Thank you for sharing all these really important points. It sounds like we need to start implementing orientation for host institutions and faculty on cultural relativity and learning more about the cultures of the participants that are coming in, and to talk about things like accent and differences in terminology and differences in expectation in the professional environment. Koa, go ahead.
Oh, I just want to give an example of what Tendai mentioned about accent and terminology, like, like staff or reserves or CDF. Those things, like, we don't pronounce that way. We pronounce the French way because we used to be a French colony. So that's something like, and when at that time I just feel embarrassed. And because some people went, what? And they just raised their eyebrow a little bit, and then those things now, as I learn more, I get to learn more about microaggressions. And I know that those tiny things, it make you feel comfortable a little bit. So those things should be I think explicit at the beginning. And also I want to touch on a little bit because my experience were really positive, because I think we also should talk about how we develop resilience and kind of protection against racism by having good mentors, and they kind of having you do the groundwork for you, they protect you a little bit, having a good mentor, and then have a good team with trust and kind of knowing the correct people to entrust the participant to can help a lot in protect against racism or discrimination. I think I was very lucky to have very good mentors and who protect me from those kind of discriminations. And always when I make mistake, they just I don't now. I still think I made mistake. I pronounce it differently. They would just say you pronounce differently, and here we say something else. So that's really kind of validation, very helpful.
Yeah, I'm glad to hear that you had strong mentors who had some understanding of some of the challenges that could have your back and advocate for you in the moment. That's something that we should definitely keep in mind as we start to discuss what to do moving forward. Charlotte, I wanted to bring you into the conversation here as an educator. Are there things that you have heard from your students or people that you've hosted on either side, or any personal experiences yourself? And also, in this list of questions, I wanted to ask you about people from your university who are going to come and be hosted soon, and what does their orientation process look like on your side?
Thank you, Mitra. I actually wanted to echo what my colleagues have just said about, this issue of accent and dressing and so forth. It's so pervasive. The impact on the individual is unbelievable. Yeah, to the extent that even back home in our own low-income countries, when teaching students, if you put them in small groups and one group has students who speak English in a better accent than the others, you find that the ones who speak English in that better accent are more vocal, they're more interactive. The other students are just quiet. So you come out with the impression that these ones who are more interactive and vocal are more intelligent than the other students. So it's just something we need to bear in mind. And I'm hoping that with this exposure, we can find ways of really addressing those issues, because my postgraduate students will come and they also feel these effects of accent and vocabulary. And, sentence construction can inhibit one from contributing valid experiences. So, fortunately, at that level of of our postgraduate students, they are more exposed, and you'd expect them to interact, but we should not overlook the effect of some of these issues. Thank you.
Thank you for sharing those insights. Another theme that I keep hearing coming up is this issue of trust, feeling comfortable to trust others and feeling comfortable to trust self, especially with the colonial model breeding a lot of inferiority, superiority type of ideation. And what you're speaking to about people with a more clear accent or acceptable accent feeling more outspoken just makes me think about the model of coloniality in countries that are formerly colonized, where often the education systems in those countries are still run by people from the colonizer nations. So of course that interaction is still going to play out while they're here in the United States. So thank you all for some really interesting thinking points for all of us on that. And I saw some thumbs up in the audience just during that particular discussion. So now that we've talked at length about some of the personal barriers and structural barriers, wanted to get a little bit more specific about what we think is driving these differences in high-income country to low to middle-income country and vice versa. Of course, we touched on the colonial mindset and some history, but if anyone has any more specific ideas or points about the root of this, I think that would be useful for our audience.
If I can come in, what I think to be maybe one of the root causes again is what you mentioned earlier, Mitra, in the earlier session, that the origin story, it has been lost. The origin story of these global inequalities, it has been lost. The average medical student, for instance, in low-income countries, I believe, does not know that story, let alone in high-income countries. So now, how do you then transform things? How do you improve systems when people do not, have not come to grip with the origins of a problem? I want to reflect back to what a student mentioned in the earlier session, that the colonial masters left us a long time ago. We should now not be going back to be talking about these inequalities or discrimination and so forth. And the answer is no, they did not leave us. They were there with colonialism. Now it's neo-colonialism. It's more subtle, and it's even more detrimental than the colonialism which was there. So, but our young people don't know this. So how can they come up with solutions to address that issue? So I think we need that education for critical consciousness. So we need to start from there. Then people start taking action. Then they can then come up with suggestions or ideas on how to address these issues. You start from conscientizing them, saying, hey, wake up, this is the situation. So what do you do about it? Let's then take it up from there. Thank you.
Yeah, thank you for bringing this up, Charlotte. And I know from my end, as someone who, tries to write curriculum on these topics, it just really blows my mind that we carry out global health exchanges without having these topics be standardized curriculum. Because as you said, that neocolonialism is so harmful, especially because in ways that it's more subtle, or it's not outright military conquest the way that it has been in the past, although sometimes it is still through military conquest, and without really bringing awareness on all sides of why this is important, how it plays out, what are the barriers, how does it affect our mindset, and why is that mindset important in the ways that we interact with each other, with ourselves in these settings. So yeah, I could not agree more. Koa, I'm curious whether you have anything to add.
I think like the colonial mindset is, and I also agree that I did not know anything of it, like colonialism, decolonializations. I know of it as the time that I was attending the global health program. That's something I learned later. So I think like I could have been done better or like contribute differently if I known those topic. And then I also think there's a very basic question about where the monies come from, like the financing structures. Right now, like it's mostly come from the high income countries. So there's always an inherent power imbalance. Power dynamic should not be like that's always there. So we have to be clear of our expectation in I think like in reality, like by participating in this CAP program, I am attending and becoming a member of a community who people from the high income country welcome me there. And I also will welcome friends and family when the students I consider friends, family, colleagues from the high income country back to my countries. And those kind of expectations are often implicit. They never make it clear. There is no I think like official validation or recognition for those kind of effort by welcoming each side, but it's more on a preciosity. It's like you mean like I give you something, you give me something back, and it's by our culture. It's a very strong sense of duty, and it should be making like more explicit. I think like I kind of like we welcome you to this kind of like community, and we would love you to welcome back our friends and families, our students when we're back. And that kind of thing should be explicit, and we feel well, there's expectation on both sides, and it's not just like I'm being lucky to be here. So those things I think can help a lot in like balancing it out and making with like we both like know the expectation from both sides.
Yeah, thank you for sharing that perspective, Koa. Tendai, I see you nodding your head. Anything you wanted to add to that?
I just want to agree with my colleagues that the colonizer mindset, colonial mentality is not something of the past. It is definitely something that's embedded in our health systems and is the root cause of a lot of the imbalance that we see in global health exchanges. And it plays out in different ways, in historical exploitation of vulnerable populations in the name of progress. So this might have been more blatant in the past, but still happens, like we mentioned, in areas of research, where a lot of credit is not being given to researchers and educators in low and middle income countries. Also the fact that global standards are being developed in high income countries, and a lot of times on these committees and on these boards, there's no input from low and middle income countries. So their side of that exchange is never going to be on par with high income countries if there are no decision makers from low and middle income countries. Another point, which has been mentioned already as well, is that diseases of poverty, so to speak, are often ignored because they're not profitable. So the needs and the concerns of communities in lower middle income countries are not put on par with some of the needs and concerns of high income countries. So in terms of community needs and assessments, we need to reevaluate how we address those, when those address, regardless of whether they bring a profit in terms of pharmaceutical companies, in terms of the medical system as a whole, and in order to equalize that balance. And then we've also touched on this point a little bit, but the white savior complex, we talk about this a lot in global health when students come to a lower middle income country, but there's also donor dependency on the other side in the lower middle income countries. And so until these issues are addressed, no lasting efforts will be made towards capacity building, because there'll always be someone who wants to swoop in and sort of fix the problem from outside. And where the problem is, people are so used to people coming and fixing things for them that there's never any initiatives and long-lasting change on their part. And of course, the last point I wanted to touch upon in this imbalance of global health exchanges is disparities in resource allocation. Until you have equal allocation of resources, and equal can't be the same. You have to look at the circumstance and the context and give according to that. So you can't give to a country in a high income country the same as you can do to a low middle income country. In order for them to be equal, that giving has to be assessed and it has to be measured to meet the needs in that context, taking into account all the historical disparities that have, led to that situation. So, to summarize, I think as my colleagues have mentioned as well, those imbalances occur on multiple levels, and meetings, discussions, bringing people in from lower middle income countries into decision-making and policy-making positions, I think is the way forward in terms of equalizing that balance.
Yeah, thank you for sharing so many more points adding to this discussion. And yeah, I think we can all agree that without some real deconstruction, reconstruction of the systems that we're working within, we're going to be incredibly limited. And some of our attempts are going to be more band-aids on a much bigger problem. So something that came up in our last panel as well that I think is so important for these conversations is, aside from trying to change things on the side of high income countries, which I think is pertinent, right? Because at this point, they do have a lot of power in policy, in research, in funding. Tendai, you mentioned this donor dependency model, and trying to, make space on high income country side for other voices. How does low to middle income country collaboration play into this, whether it's on the mentorship level or on the curriculum building level? And Charlotte, as an educator, I'm really curious what your experiences have been with this, and if you've had any ideas with your program that you're building.
Sorry, I had muted myself. Mitra, may I ask you to repeat the question, especially the tail end of it?
Yeah, absolutely. It's a very broad question, but I'm curious your perspectives as an educator, what opportunities they are for low to middle income country collaboration when it comes to hosting students from low to middle income countries and high income countries, especially in light of earlier points made by Tendai and Koa that they were very limited in their interactions with other people from low to middle income countries, be it people from their own institutions who had come or other people on the ground or in research. So very, very broad question, just opportunities for intercollaboration from the LMIC side.
I think opportunities for collaboration are numerous. And I think they should start from, they should start from just communication, communicating and interacting before we get to the physical visits. You can imagine if, say, we established general clubs between low-income countries and high-income countries, and students and faculty are interacting online on the general club topic. From that, topics for research projects can come up, and those can be followed up. And I see then visits, physical visits coming in as well. So some relationship needs to be built before the physical visit. So we should know each other to get to a certain extent of actually knowing each other before we visit each other physically. Then we need that bidirectionality, which is uniform. You come to my place, I come to your place, I see this, and I also see that, so that from this kind of exchange, inter-exchange, we generate ideas and visions for transformation. Thank you.
Thank you for sharing that. I love the idea of starting these relationships before the on-the-ground experience happens, because relationships take time to build, as we know, and it can be hard to find that time in the midst of all of these cultural differences and clinical hospital hours and all of these things. And I think building that relationship earlier can also encourage the longer term mentorship and research and projects and collaboration that can be born during that time. Tunde, your hand is up. Please share.
I did just want to touch upon that idea of building relationships before online through journal clubs, informal meetings, case discussions, what we were discussing before in terms of accent and some of those personal discriminations. As people interact with each other more, even before a physical visit, as my colleague mentioned, we get used to each other. We get used to how we speak, how we operate within our own environments. And so it's not such a shock to the system when we do meet in person, either on the high income side or the lower income side. And so making use of technology in this way, in terms of just cultural competency and getting to know each other, getting to know our health systems and how we operate on a day-to-day basis, I think will be beneficial as well.
Yeah, beautifully said. It sounds like I'm hearing you say that maybe building those relationships earlier on can help overcome the barriers of culture and kind of help humanize all sides and make those difficult moments a little bit less difficult. So I see that there's a comment in the chat and we're about time for a Q&A. Before I get to that comment, I wanted to ask Koa if you had anything you wanted to share on this idea of LMIC intercollaboration.
I'm on about it. And I think like it should not be only limited to like clinical medicine. There's a lot we can learn from each other about like healthcare system and health management and health professions, educations, health and research. Those things I think are really making us like how to say, like making it more like holistic and collaboration. And for like as an individual level, like people have different trajectory and career development, so that at individual level they can see how they fit in to this kind of like relationship between like LMIC's countries. I think like we should be not be just focusing on like clinical medicine, and we should be like whole like education also. And I think like we have to get that kind of like multiple exposures, multiple talking, and like and at least like like last time I attended the Global Health Date. I think it's fantastic like event that I can get to meet in person people and friends, colleagues and friends from like other LMIC countries in the US. And I think it's a fantastic opportunity and a good model that we should continue to do it.
Yeah, no, thank you for that, and agree that we should be expanding outside the clinical realm in that. Charlotte, go ahead, your hand is up.
Yes, thank you, Mitra. I've just remembered I wanted to make a comment about this observer thing where students from low-income countries can only observe. When they're in high-income countries, they can't touch a patient or anything. I just wanted to say that from an educator's point of view, you are interrupting the learning cycle when you do that. Because when theory is introduced, and you stimulate the student, and the student now is now eager to apply what they learned in class on the to put it in practice, to apply it. But now if you stop them and they are to observe only, you are kind of interrupting that process. So that's what I wanted to say. Thank you.
Thank you for sharing that perspective from an educator. Yeah, absolutely. I can see where you're coming from on that. And I imagine that it's so difficult to also be balancing the emotional experience of observership with the general confusion and culture shock of being in a place, along with programs that are a little unstructured, so you're not really sure what your role is. So I think it sounds like there's multiple stressors on the learning experience sometimes. So thank you. Oh, Koa, were you going to say something?
I want to say that, like, I also noticed that, like, given our current situation of being the sole observer, we should make as more as explicit as possible, discuss about like your, like, take advantage of the opportunities, and those are the benefits that we have been studied and evaluated, so that it can be like, you know, like know and anticipate in advance. I think that's very important, and how they can fit into their career development. And I think this kind of like global health program should not end when we end our time in the US or the high income countries. It should be a continuous like follow-up collaboration. And especially when you're not focusing on the technical side of clinical medicine, you will touch on we call it adaptive challenges. Those things work with the system, with the culture. So those things should have the continuous support from other countries, from the LMIC countries and both high-income countries. So that's kind of thing when you, like myself, I have to learn about medical educations because I focus only on the like adaptive challenge. I didn't have a chance to focus on the technical one. I cannot do any ultrasound. So that was my interest at that time. So I need continuous support afterward. And when you deal with the system type of challenge and not like a technical challenge. So I think like it should not end here and should have follow-up.
Yeah, thank you for sharing those points. So tying in those points to some of the themes that have already been mentioned, we are hoping for more long-term engagement, starting from before somebody comes to be hosted at a high-income country institution, through their time with real in-the-moment support when needed, all the way through longer-term mentorship on the return home as they try to reflect on and integrate some of the things they've seen and learn, and that they would like to see translated in a culturally sensitive way into their home environment. And yeah, so now I wanted to call on Thomas in our audience. Thank you for your comment. If you don't mind, we'd love to hear you voice it in real time and expand a little bit.
Thank you, Mitra. I hope you can hear me loud and clear.
Yes.
The topic of discussion is really very important. I have taken part in some of the observerships. I've been at Des Moines University. I was a student. Then last year, I was at George Washington University in the emergency department. And then I was in University of Vermont Medical Center and Porter Medical Center just a couple of weeks ago. I think the thing that I have seen in these observerships is that, yes, they can be helpful in terms of if you come when you know the goal of this activity, because if you're not goal-oriented, if you don't know what is in it, what like it means to do an observership, you may not benefit a lot, because in our setting here, we are used to seeing a patient, you go cannulate a patient, do this, do that. But there you only see, I mean, there reaches a time when even they're in maybe there's a critical resuscitation, someone has got a cardiac arrest, and I mean, all you can do is watch. They need a pair of hands, but I mean, you can't do. It feels bad at times. It feels boring. You may feel helpless, but I think even in such circumstances, I think from this little experience, what can make it better is, if there are patients that not so critical, not high acuity patients, I have had my supervisors allow me talk to. Someone has come with a minor cut on the hand, you go speak to them, and just speaking to a few patients, it makes enjoy that. You're not touching, you're still observing, but you can speak. And the other thing is that maybe the fear of HIPAA and all these policies. Some institutions have like a course that you do so that you get immersed, what is supposed to be followed. Like UVM has something like that. So we did that, and at least I knew that this is, you can't do this, you should do this in such a circumstance. So I think having such also a training that, someone that in this setting, we expect you to at least try to communicate in this way. You don't say this, don't say that, so that it allows you at least to speak to the patient. I don't know which much harm you can do to a patient when you speak to them. At least only speak to them. I've not touched, I've not sutured, I've not done anything, but I've spoken. So I think something like that we should work towards. Like, it's a gradual process, but at least start with talking to patients, and then maybe move on to do the hands-on bit. The other things I saw is that pairing you with residents or with students, depending on the level you're at. Then also, if you have faculty that have had global health experience, when you see a patient together, you come, you discuss, this is what you do here. How would you do this side? But it can get really so like passive if you have people who have no global health experience and they're not interested in hearing from you. You're just like their tail. You're just following behind them. And I don't think there's much learning when the interest is very low. And then there are a couple of other activities still that maybe as we plan such activities, such like exchange programs that can be helpful, like simulations that we don't have in such countries. When you go there, take part in a simulation. In a simulation, even if you make a mistake, patient has died but has not died, it's a simulation. So such things, they also help in learning and also triggering like someone's mind to improve medical education from wherever they are by having participated in such sessions. Thank you so much.
Thank you for sharing your experiences and adding to this conversation of what can be done differently, what can be done better. It seems that an interesting point that you brought up is that, yes, we are limited, but there are things that can be done that there are no rules against, right? So really trying to capitalize on the opportunities that do exist, like procedural skills lab, simulation lab, emphasizing patient interaction, even if it's not specifically a history taking or a physical exam, there can still be meaning found in that. And, just in the meantime, as we try to collectively find ways to overcome the legal barriers, which obviously is a much bigger process. Any of our panelists wanted to add to that? Oh, actually someone, yeah, we have a few comments in the chat as well about a resource that might help the need for decolonialism education. Thank you for that. And Justice, I saw that you put a comment, but do you want to speak up and tell us more about that?
Thank you very much, Maisha. And they're interesting topics. I remember my first experience with global health was when I were for capacity strengthening, and that was in the UK. And I remember going to various hospitals, and we used to I would first observe, and afterwards would work along like any other student. And I go along with them, and there are some activities you find that you would have hands-on, you participate, but not as you, but working with those who are with you. And here in Uganda, when we are teaching our students themselves, even when we are sending them for placement, we tell them that they are not licensed to practice it. Hold on, much as they practice, they are doing it under supervision and they can never do anything independently. And so when I mentioned that observership can be branded by recognizing the policies and regulations that are guiding, I think when participants from low income countries go to higher income countries and they find themselves restricted to just do hands-on, I think it is also good to appreciate that. It could be in the weak policies of the law setting, and these weak policies come in not because they don't know what is right, but because of the way they find themselves. First of all, they go along and touch. So it is not a case of saying that there's kind of maybe being sidelining and denying participants from low income countries to have hands-on, but it's because of the policies that are in high income countries. And all of us, we should yearn that we are at such a level where we do not just allow participants to just touch patients and practice actively when actually we are not sure, because even medical practitioners here, they have to pass through licensure and they continue renewing their licensure. So I think it is the limitations and weaknesses of our setting that we would find ourselves feeling that when theirs come, they touch our patients. How about us when they go? Why shouldn't they touch their patients? It is the policies, and we should all strive to reach there, that patients shouldn't be touched of going there, and we know we are students and find a means of working along with others. If they go to theater, they don, you also don. It does not stop you from holding a forceps or pass a scalpel and or hold a retractor and learn while the procedure is going on. And the main reason of observership, we can learn better from it, like somebody said, when we are focused and we know our goals. You observe, you see what is happening upon what you have seen, and you make it active learning. Learning is both observing, because there are multiple intelligences as far as how learning takes place. Because learning not only does it take place when you put hands on, and having a chance to go and see what is there opens your worldview. And as far as global health perspectives are concerned, it is not only just touching, but it's developing attitudes, developing comprehension and draw perspectives and continuum of looking at things, something like that. So observership is so important, and those who get that chance should really utilize it. And when you need to put hands on, you just help. When you want to learn, when you come back, you will deal with your patients. But observership should not miss out simply because of differing policies, and everyone would need that we have such policies and we have resources that are enough to make sure that even here you don't just touch patients anyhow. Thank you.
Thank you for giving us some more ideas. So some of my takeaways from what you shared with us is that, again, despite the structural barriers, there are opportunities to be involved. And we have talked about previously in our discussion, things like simulation lab or conversation with patients. You mentioned an active learning component, and I think something we can add to our list of possible solutions is being very thoughtful and intentional about what opportunities are available. And even in the process of observership, if a participant is seeing a topic they're interested in or something that they're moved by, to give them opportunities to do something active while they're there on the ground within the limitations of the legal structure, whether that's a research project or a presentation or some kind of collaborative thing with the team. Yeah, we have Sabrina also talking about the importance of culture shock and sensitivity, which of course is part of the challenges that participants are going to experience while they're in the United States. Sabrina, can you please tell us more?
Thank you very much, Mitra, and to all the panelists. This was a great discussion and insight. From what the panelists were sharing, sometimes the frustration plays out with people getting angry or sometimes even depressed. So people need to be prepared, and also there should be care providers to support exchange students, for example, who may get culturally shocked or even get frustrated and depressed. There are so many things that could give you a culture shock. For example, what Tindai shared, having to be all dressed up versus wearing scrubs, or even the way things happen. So we just have to be culturally sensitive and respectful to wherever our students go or when they come here. Thank you.
Yeah, thank you for sharing that. I think kind of back to this colonial mindset and model, what's really interesting is that often not only is the mindset, like has been mentioned, that participants from LMICs coming to high income countries to be hosted are in a lucky and fortunate position, and that their experience being here must automatically be everything they want it to be, but also that the culture in Western high income countries is the default culture, that everyone's already had exposure to it through media, through conversations, through visitors from international places, and that this is the not only the dominant culture, but like a better, sometimes more liberal culture as well. And so I think sometimes the assumption is made that people will not be experiencing culture shock when they're on their rotations or electives, and that actually they'll feel some kind of comfort or just excitement to be exposed to those cultures. And I'm seeing some nodding from Koa and Tendai and Charlotte. So I'd love to hear what you all have to say, but just a heads up that we have about 15 minutes left. So let's keep the answers short. And I'd also like to give an opportunity for any final questions from the audience.
I do just want to agree on that point in terms of culture shock is often one way. It's often when people come to lower and middle income countries that culture shock is spoken about, and there's counseling and other avenues that are available to help participants deal with that, and it doesn't necessarily happen the other way. And like you mentioned and others have mentioned, it's just that inherent idea that a lower middle income participant is lucky to be on this rotation observership, and they should be excited, and that should be the feeling. So any other feelings are not addressed because it's just assumed that that you're in the state of excitement and the state of awe from your rotation in a high income country that you've never experienced before. So no one is going to why are you depressed? Why are you angry? You shouldn't be, because you're lucky. And so just again, having that understanding that culture shock goes both ways. And even though lower middle income country participants are exposed to American culture through television, movies, all of that, it's different when you experience it in person, and that needs to be acknowledged.
I also want to share from my experience is that what the media tells us often has been beautified under rose stained glass, and then the version of America or other higher income countries can be different when we experience it. And I think it's opportunities for learning for both sides when we discuss about area we can improve in both sides, because we know that the US has struggled a lot in different areas, like COVID-19, the US struggle, health inequities, racism, how different things can be interact within those kind of when we talk about the US, it's not on roses. There are different things that we can learn and discuss as equal partners. So I think that culture shock for me lies, I take it with humble, I come with humility, and I come to the program with humility, and I want to learn. And when I notice that like there are areas that the US or the high income countries also struggled, I know that we can learn from each other.
Yeah, thank you for that, Koa, and very astute observation about the differences in the ways that countries are represented in the media. Charlotte, anything you wanted to add before we have a final question to our audience?
Maybe just one small point about diet, the food, as a source of a culture shock also, or a source of maybe discomfort, if I may put it that way, because when we visit from our countries, I don't see effort from this other end to maybe provide what I'm more comfortable with. But I guess that would be difficult. But it's like you just have to put up with what is put on the table. And some of that diet is, very different. It's a small point. Thank you.
No, I think that's a really important point. Thank you for bringing that up, because I think it can be so difficult to be in a place that's new with people that you don't know. There's so many elements of unfamiliarity, and those creature comforts that make you feel grounded to things you know and are comfortable with become especially important when you're traveling. And I think one of the inequalities and again, structural barriers is that as a student from a high income country going abroad, you often have easy access to any kind of food that you want to have. And certainly American food is very easy to access when you're abroad, but maybe it is definitely harder to have access to food from, your home country when you're in the United States, not necessarily because we don't have your nationality represented in the United States, but again, because you might not have transportation, like you might be relying on other people to go get it, like it's probably pretty expensive, So that was all very, very good point about creature comforts and tying into what Dr. Sabrina was saying with culture shock. So before we close, I just wanted to ask if there were any final comments or questions from our audience. Thank you for being so attentive. Okay, it looks like we don't have any more questions from the audience, but thank you for your comments. So in closing, it seems like we've covered a lot of ground, and this discussion was very fruitful and a topic that has not been discussed too much before. Oh yeah, Joshua, thank you for your comment. Do you want to share with us, with your voice, the project that you're working on in curriculum?
Thank you, Mitra. Thank you all the panelists. I'm Joshua Maskama, medical student. This has been really a very educative session. I really wish more of us were joined in, but yeah, we shall share. The few of us who are here, the medical students, shall share with the others. Anyway, briefly, we are also doing we have a decolonization interest group, MAC chapter, and we are doing a study on introducing a curriculum on decolonization and of global health in Uganda. The title is Introducing a Curriculum on Colonization and Decolonization of Global Health in Uganda, a Pathway to Equitable and Culturally Sensible Health Care. Yeah, briefly, anyway, we found that as most of the people mentioned, we found the need to, because we discovered that trainees, there was no literature or information on how medical students and other trainees perceive colonization and decolonization. And we aimed to assess their perceptions, attitudes on integrating such a curriculum. We are also assessing the current state and then the feasibility of such a curriculum. Anyway, in short, the study is already received. We received conditional approval from the IRB, and we shall be assessing this in all medical schools in Uganda. I believe this will be a huge step, setting the course of decolonization and eventually having a curriculum set up. Yes, Mitra, thank you. Because of time, let me end there. But it was really informative, and we thank you very much.
Thank you, Joshua, for sharing this very exciting project with us, and please keep us posted on how it goes. We're looking forward to seeing the results of that. So yeah, in closing, we have covered a lot of ground today. We started out talking about some of the positive components of these exchanges, and that was reinforced even with our Q&A with the audience and comments that observerships, despite the limitations, are still valuable, and they can give a lot of exposure to new technologies, seeing teaching styles, like Charlotte mentioned, being played out in real time. And at the same time, there's a lot of things that have room for improvement. We covered culture shock, the importance of mentorship starting out from before someone even comes all the way through the end. We talked about how the meaning of those relationships can really be built in a way that can diffuse some of the discomfort and maybe cultural tension that we can notice on the ground during the rotations. Koa brought up a very interesting point just about the moral injury and some of the like self-victimization that can happen within the superiority and inferiority complex. And yeah, it sounds like we have a lot of ideas to work with in terms of being really intentional about creating a solid structure with preset expectations and learning objectives and ways to assess whether those learning objectives are being met, having debriefing happen on a regular basis so that we can address issues that are happening for participants as they're going on, in addition to debriefing sessions with supervisors on both sides to try to invest in quality improvement down the road. And really trying to bring home this theme around agency and giving participants some agency and voice and emphasizing what they have to bring to the table, creating opportunities for them to share their expertise and insights with high-income countries to try to combat this idea that they have less to contribute and try to build more trust all around, because trust is a theme that I feel came up so many times in this, again, whether that was trust of self, trust of others. And yeah, some of the takeaway points I just wanted to summarize from each panelist. So Tendai really highlighted the need for practical and detailed outlines of what bidirectionality looks like and how it will be executed. The need to teach decolonization and health equity, social determinants of health to ensure that there is a lasting systemic change moving forward. Koa really wanted to drive point that participants from low to middle income countries do benefit from these observerships, but that the benefits should not be taken for granted. We need to be more intentional, mutually and realistically discussed and evaluated. And strategies for minimizing these power imbalances, making them explicit and recognized, focusing not only on challenges and deficiencies, but on the solutions. And this idea of the bilateral partners, we are on the same team. All parties are, striving for the same goals, and we really need to find opportunities for LMIC alliances, whether, again, that be in the form of like peer support, mentorship, collaboration. And Charlotte also spoke to how many opportunities there are for that in these exchanges. And finally, Charlotte really drove home the point about the colonial mindset being such an integral part of this, which is something all of us remarked on at different times in different ways, that the decolonization movement cannot be led by people in high-income countries. And these suggestions and actions should really be homegrown, starting with education for critical consciousness and the health professions education. So with that, thank you all for joining us. We really appreciate your attention. And I want to give a special thanks to the many, many people who helped put this on. Give me one moment. So we have Declan Currain, who's the chairman and managing director of the Science Summit at the United Nations General Assembly Science Summit, who has been so supportive of our group and our team and helped us from A to Z. Pilar Gomez, who's the co-chair of the Science Summit, who has also helped us backstage A to Z with all of the details. Amanda Wallace, our creative editor, who is also always helping us with our imaging and this background. You can see here our Nuvance Health logo. Thank you, Amanda. And Swapnil Parve, the co-convener and of these sessions, and who's taking on a lot of roles of the technological aspects and behind the scenes work that we wouldn't be able to do ourselves. And Majid Siddiq, who is the convener of this event, who also made this possible. So thank you so much, everybody, for joining us, and looking forward to more discussions on this topic in the future. Have a great day.